Hello, I'm Dr. David Cotter, a board-certified dermatologist practicing in Las Vegas at Las Vegas Dermatology. And this year at Derm 2026, I'm speaking on a fun topic, the Emerald City Exhibition of Innovation. And in this session, we took a deeper dive into some emerging technologies that can help us augment the care we give our patients when it comes to moles and melanoma. The first part of the talk focused on an AI-augmented handheld tool that we use in the clinic to guide biopsy decisions. It helps us risk stratify how likely something is to be an atypical mole or hopefully not a melanoma. The way this technology works is it uses something called electrical impedance spectroscopy, meaning a very small current of electricity that is painless to the patient. You can't even feel it. But what it does is it measures the resistance of that current through the skin lesion. And when more melanocytes are atypical, it changes the way that current flows. And that's detected by the receptor coupled to an AI algorithm to give you a risk score of how likely it is to be a melanoma. And we've been using this in our practice now for a few months, and it's actually significantly improved our hit ratio. It's cut the number of biopsies we need to do to find one melanoma in half. After that, we focused on some updates in the gene expression profiling realm, particularly as it relates to thin tumors, because thin tumors are what the majority of us see in clinical practice. 80% of melanomas we diagnose in the United States would fall under the categorization of essentially a thin tumor, meaning a tumor less than 1 millimeter. And we've got a 31 GEP test that can help identify which of those thin tumors are at increased risk for metastasis. There was a cohort of patients that was reported just a few months ago, about 750 patients with tumors less than 0.8 millimeters. By definition, these are the lowest risk melanoma patients we can find. Despite that, there was a group of them that had a lower than expected melanoma-specific survival. We'd anticipate the survival in a group like that to be about 97 to 98% across the board. But in higher risk gene expression profile patients, that rate fell to 87 to 88%. And it turns out that 1 in 12 patients actually fit that bill, meaning your hit ratio for a patient that has increased risk, if you order this 31 GEP test on all comers with a tumor less than 0.8 millimeters, is 1 in 12. I'm pretty comfortable ordering a test that's going to help me improve the lives of at least 1 in 12 patients. And that was a nice update. Similarly, as we march towards deeper Breslow depths, there was a new prospective study in the sentinel lymph node biopsy space that came out in mid-March. This is a study that looked at the role of a 31 gene expression profile test to help guide the decision to do a sentinel node biopsy or not. This was a prospective test that demonstrated a few things. One, that the test itself will influence the clinician and the patient's decision to do a sentinel node biopsy. But even when patients do choose to have a sentinel node biopsy, it accurately predicted which patients were likely to have a positive node or not. When the test predicted a low risk of sentinel node biopsy positivity, particularly in patients we care the most about, these intermediate patients, folks that are T1b to T2a, the rate of a true positive was only 1.4% in the low risk category, which is great because the NCCN guidelines recommend avoiding a sentinel node biopsy in anyone with a risk likelihood of 5%. Meaning the test beats the spread compared to standard staging. On the flip side, however, when the test predicted someone had a higher likelihood of having a positive node, meaning greater than 10%, at which point the NCCN guidelines would recommend doing a sentinel node biopsy, the true positivity rate in that group was 18.4%. Clearly, we're able to risk stratify patients that are low risk and those that are high risk, which provides meaningful clinical information. And then to wrap up, we talked about some emerging use of circulating tumor DNA. If you haven't heard about that yet, essentially it's doing a liquid biopsy to help monitor your patient's likelihood of recurrence for high-risk skin cancers. It's actually recommended to be done for Merkel cell carcinoma in the NCCN guidelines, and we're doing it increasingly more frequently in the melanoma space as well. Not only can it portend a recurrence sooner than radiographic detection, but can also predict response to therapy. We see circulating tumor DNA drop off over time as patients go on therapies such as immune checkpoint inhibitors. If you weren't able to join us, hopefully that gives you a high-level overview, and we hope to see you next year.